नौ पीपीटी बड़ी कर लो।
नहीं आया अभी
डॉटेड नहीं गया बस।
ये कहाँ से आया?
स्टार्ट वीडियो।
नहीं स्टार्ट वीडियो नहीं कर रहा। कुछ नहीं करो।
ठीक है
पीपीटी चालू कर लो।
ठीक।
आपकी आवाज
So, as WHO defines any person who's having hearing thresholds more than 20 dB or more, and one or both ears is said to have hearing loss, and it is often categorized into mild, moderate, severe, or profound. It can affect one or both the ears, and it leads to difficulty in hearing conversational speech or in hearing even the loud sounds. So now, what are the common symptoms and signs which a patient or a parent may report you with? So the child has, first and the foremost important parameter is when the parent says ki bacha bolta nahi hai. So the child has delayed speech and language development. He is asking for repetitions, not waking up to loud sounds, not responding when his name is being called, unable to locate a sound source, places his ear near to the television or speaker or raises the volume. Speech development has slowed down or it has shown a regression. Poor speech intelligibility. Does not notices the loud sounds in the environment. So these are the certain signs and symptoms if a parent is presenting us with that alarms us to go for a hearing evaluation, because the first and the foremost reason why a child has not started speaking could be that he is not even hearing the sounds. So briefly covering the causes, they have been categorized into prenatal, perinatal, and the postnatal causes. So the prenatal causes are family history of any deafness, consanguineous marriages, any RH incompatibility or blood group incompatibilities, any infectious disease that the mother does contract during the early trimesters, and if the mother is indulging in some sort of substance abuse, intake of ototoxic drugs, or even exposure to radiation sometimes has resulted in hearing loss in kids. Very common causes of hearing loss in perinatal phase could be birth asphyxia, delayed or a feeble birth cry. Very often when children who are reporting to us report that the child has had a delayed birth cry. So this could either lead to hearing loss or it could also lead to intellectual disability. So if they have a delayed birth cry, they need to undergo, we would categorize this child as a child in high risk register. Or having a birth weight less than 1200 grams, even low APGAR scores could also be indicative that the child may be at risk for developing some or the other issues. There are certain postnatal causes as well. If the child is premature, if the child was born premature, that could also be one of the reasons. Sometimes we see there are deformities of the ear, nose, and throat. Yes, most of the kids develop jaundice after getting born. So yes, if the jaundice becomes worse, it is one of the definitive causes of hearing loss. Again, infectious diseases such as meningitis, which is very commonly seen in kids sometimes, that also is calls for a hearing assessment. Any head injury, continuous exposure to loud sounds, also middle ear infections, which are very common in children. So if any child is reporting with very frequent cold and cough issues, they also need to undergo hearing tests on a routine basis, because we do understand that hearing loss is not only of a profound nature. There are cases where we have seen the child only had a mild hearing problem, which if left unnoticed could lead to increase in the severity of the problem as well. So briefly touching on the audiological assessments that we usually do at the center. So we do subjective assessments comprising of behavioral observation audiometry, visual reinforcement audiometry, play audiometry, and pure tone audiometry. In behavioral observation audiometry, basically we are just observing the behavior of the child in response to the sounds that we give. So we have placed the child in a sound booth room and we give sounds to the loudspeakers, and we check that how subjectively they are responding to sound, whether they are responding to only loud sounds or they are responding to soft sounds as well. So this is basically done for very young kids who cannot sit and participate and give reliable responses that I can hear. One of the very common tests that is done is pure tone audiometry, wherein a child is put with headphones and we give sounds, and we kind of teach the child to respond whenever they hear the sound. So this is a very subjective assessment, but this is only possible in kids who are 3.5 or 4 years and above, because they only can follow these instructions. So for very small kids, starting from almost 1 day of age to almost 3 years of age, we follow the objective test, so to speak. So in this, we are including auto-acoustic emissions, ABR, which is auditory brainstem responses, or BERA test, which is commonly called, ASSR, which is auditory steady state responses. And there's a middle-ear test that we usually do for kids who are prone to more cold and coughs very frequently. That is called tympanometry and reflex testing. So autoacoustic emission is basically, I think we all are familiar with. It's the most practical method for screening infants because it's very quick and it is performed with a handheld portable screener, and it checks the response from the inner ear, basically. So what is the phenomena here is we give the sound and there are certain emissions that are generated at the level of the ear, which are recorded by the instrument. So if the sound is coming and it is getting recorded, means it's a pass, the child has passed the hearing screening. So this is done for all, this should be ideally done for all the babies. And it only takes few minutes, it's quite cost effective. It's not a lengthy procedure, no sedation is required, it's a very safe procedure. So present OEs are consistent with normal hearing. So if the child is getting a screening done and it's a pass, so we can fairly say that the child will go on to have normal speech and language development. If not, then we usually like to tell them that these are the stages that the child should follow in their speech and language development. If it is not coming, then please go back to the pediatrician and consult with the sources. So OEs could be sign of some problem. That could be hearing loss, it could be wax in the ears. Sometimes when the children are born, they are in the fluid environment inside the mother's womb. So there could be fluid in the ear also, which could result in negative OEs. So there's a whole protocol which we'll be discussing the next set of presentation, how should we refer for the re-screening to the child. Coming on to auditory evoked potentials, categorized into ABRs and ASSRs. So in both the tests, we basically place the electrodes on the forehead and on the mastoid regions, and we give stimulation through the ears, and we record the activity that is generating at the level of the brain. So while we are doing ABRs, it's a very comprehensive and diagnostic test that is done, and it checks from the external ear till the higher centers of the brain. It's quite confirmatory with respect to the site of lesion, where you are exactly expecting the problem to be. And it is more diagnostic, as in it will tell you whether the nerve is also responding or not, because these days there are conditions in children wherein you may get responses, but the nerve is not responding due to some maturational delay, or there could be origin neuropathy, wherein the nerve has not got the myelination sheath and the auditory stimulation is not reaching the brain through the nerve. So all this is very checked in a very detailed manner through ABR. So we personally recommend and request all of you that if there's any child who's having who's failed the hearing screening once or more than once, they should undergo ABR, because that puts all the doubts to rest. Yeah, it's the same as well. It's the same.
And do you sedate for that?
Yes, sedation is required, and most of the time we usually give the normal cold and cough medicines only, like pedicloral was given earlier, Phenardin, and that is safe enough.
But very small newborns.
For newborns we need not, because they're anyways sleeping.
Post breastfeeding.
Yeah, while doing that. So it's not
How long
affected
does it
much.
take?
Like 30 minutes or so. If
Ma'am,
the
screening
child is
can
there.
be done within 10 to 15. We set some intensities at that level. So if in screening we find some issues, then we have to do that.
So basically, it's non-invasive, but yes, we require sedation because it goes on for a longer time, and it diagnoses the degree of hearing loss, whether it's a central pathology or it's a peripheral pathology. That will only be told if you do a BERA test. ASSR is again auditory steady state responses. It tells you the responses at each frequencies. However, this is not very reliable because it is we have observed in our clinical practice that it is affected by the noise. So if there's a little noise, then the responses can go haywire. So we still go back to the gold standard of ABR. ABR is the best test for pediatricians.
ASSR is?
Auditory steady state responses. So it's basically that you are checking the hearing at each frequency. So it's stimulating different regions in the ear that are corresponding to different frequencies. But since we have seen in the clinical practice that if you have more noise, the test can go haywire. I mean, the degree can be wrongly suggested. So we still say that ASSR alone should never be recommended. It should always be said that ASSR to be done with ABR, if at all.
Then
So
why to be
ABR should
done
be
only?
correct.
Why it should be
Just,
done?
just to confirm,
Basic
it,
difference.
sometimes
Frequency specific
If we
responses
want
we
to
get.
see-
We get frequency because ABR will only tell the site of lesion. Sometimes it tells कि इतनी intensity तक वो सुन रहा है. It doesn't tell कि high frequency loss है कि low frequency loss है, because these complex conditions are also there. Sometimes children have good low frequency hearing, but the high frequency is affected. That is why speech is not clear. But it is difficult to catch क्योंकि वैसे वो सुन रहे होते हैं. So that's
also one more thing. Sometimes we don't get babies who are fully sedated. They are active sometimes. So we are not able to do ABR properly. So we have some doubts कि ये हो सकता है नहीं हो सकता है. In that condition we can do ASSR also. Confirm
इसमें
our.
sedation नहीं चाहिए.
sedation तो
दोनों
इसमें
में
भी
चाहिए,
चाहिए.
दोनों में चाहिए.
Just to
दोनों का रिजल्ट
corroborate.
आ जाएगा तो we can correlate more.
Correlation.
I think one of the reasons we prefer ABR is because it is more reliable. Because most of the times it picks up the pathology. The only catch is the ABR requires a trained person to report it.
Yeah.
ASSR is reported by the software. So that's
It's
the ease of
automatic.
it.
So then again, tympanometry, this is also a widely done test in cases of middle ear issues. So children who are having adenoids or who are undergoing tonsillitis, they tend to have middle ear issues and should be recommended for a tympanometry testing at least. So as I already had discussed, subjective tests like behavioral audiological assessments, they are done in a soundproof room, and we present sounds and we see how the child is behaviorally responding to different intensities. So it's not very specific, but then again, sometimes while we are doing the testing with the devices, they do not correlate with how the parent is reporting. So to check it, it is important that we also do the subjective assessments, because sometimes parents have come and said that child is not hearing, child is hearing. And when we do the test, the ABR says it's negative. So it is indicative of a pathology called auditory neuropathy, wherein the nerve is not conducting the sound appropriately and the child will have difficulty in hearing and learning speech and language appropriately. So air conduction and bone conduction tests, very widely done. Put the headphones, give the sounds and record the responses. And condition play audiometry and speech audiometries are also done to see how the child is responding at different, how they are understanding speech. And then we move on to the amplification option. So primarily we all know that hearing loss is only three so far identified amplification options. One is hearing aids, which are the conventional and non-implantable solutions basically, wherein depending on whatever hearing loss a person has, the hearing aids are given and it is adjusted according to the hearing loss of the child. The second solution is a cochlear implant. So it's basically a prosthetic device. It's an implantable solution which bypasses the damaged inner ear and directly stimulates the auditory nerve, and that sends the signals to the brain. And it is mostly done in children who are having more than 70 to 80% of hearing loss. So in children who are having severe to profound hearing loss, cochlear implant is the best solution. And we have received beautiful outcomes if we start early at an early age. And there are other implantable solutions that have started, which is the bone anchored hearing aid, Baha devices, mid-ear implants. So they are done in specific conditions. The candidacy criteria are all there set in, but most widely what we are working here these days is on hearing aids. If not hearing aids, then yes, cochlear implants is the thing. Yeah. So at this juncture, I would like to request Dr. Shashank to come and help us highlight the importance of cochlear implants. Sir is a ENT surgeon and he's working at Manipal hospitals, and he's a very good pediatric care surgeon.
Get out now.
यहाँ से minutes करें. यहाँ जाइए pen drive. ये क्या? हाँ ये.
Right. Good afternoon. I'm Dr. Shashank Kochik. I'm an ENT surgeon from Manipal Hospital, Gurgaon. Manipal hospital used to be called as Columbia Asia Hospital. So recently been overtaken by Manipal. So we are now Manipal Hospital, Palam Vihar, Gurgaon. Just for your sake, there is Manipal Hospital in Dwarka. So yes, tomorrow is a World Hearing Day, and today we are here as a professionals who can easily or early identify hearing loss. We can intervene at early stage, and we can bring back these hearing impaired kids into life. See, it's been said that sound to life is like food to the taste, a taste to the food. Okay, so we want to restore that hearing to the child as early as possible, so that they could enjoy their life as tastefully as any other. So why is early hearing so important? Okay. See, the most crucial period for speech and language development is first 2 to 3 years of life. And that is the time we want a child to have a normal hearing, so that the speech and language development is normal. Okay. And most of the hearing impaired children, they miss out because most of the times the parent do not know whether the child has a hearing loss. They think कि वो late बोल रहा है, चाचा मामा ताऊ late बोलना सीखे थे, तो हमारा बच्चा भी late है, and he'll do fine. And by the time they realize he is lagging behind his peers, and they bring to the audiologist and then to the surgeons, it's already 3 years of age. And that by the time we use that crucial period where we can give the ability to develop speech and language. See, the most important thing here is neural plasticity. The neural plasticity, it exists because the certain cortices in the brain, they are hardwired for a certain stimuli. So there is an auditory cortex for an auditory stimuli. If the auditory stimuli is not provided in these cortexes, they don't mature. And that's the reason the hearing is to be present since very early in the lifehood. And deafness, it significantly impairs the maturation of these cortices. And what so happens is, let me tell you how we all know how the hearing works. So the sound which typically goes from the external ear to the middle ear, amplified through ossicles, goes to the cochlea and then to the brain through the auditory. The same thing, just consider as a sound stimuli going all the way through natural hearing into the brain. And we know that hearing is undertaken by inner air cells, which are part of organ of Corti. These inner air cells, they have dendrites which become the cochlear nerve, and they take stimuli to the brain. So this inner hair cells, they go to the brainstem, from brainstem significant crossover to the other side and go to the auditory cortex in the temporal lobe. Okay, here we realize that close to auditory cortex there is visual cortex, and this visual cortex is, it's our enemy number one. So whether it takes over the auditory cortex when the auditory stimuli is not there. So in hearing impaired individuals, this visual cortex takes over the auditory cortex, and that's why these children, they have a very good ability to understand gestures. Nobody teaches them how to lip read. Nobody teaches them sign language. They automatically do it on their own because the visual cortex is magnified. So we say either we use it or we use it. That's why hearing loss becomes an emergency. So children with significant hearing loss, we see mild hearing loss most of the times after ear infection, but significant hearing loss, it requires an early diagnosis, and that's why quick referral is important. So why early identification is so important? Because what we know is children who have been diagnosed before 6 months and they have received an adequate treatment, they develop normal speech by the time they reach the school age, school going age. And the goal of the intervention is to prevent any adverse effect of hearing loss, and that's why early identification and treatment is crucial. Now, this is just a graph which shows the cortical auditory evoked potentials. Blue thing is cortical evoked potentials of a CI child who's been implanted with cochlear implant, and it is as good as a normal hearing individual, provided we do it in the early phase, before 2.5 to 3 years of age. Later implantation, if you see this purple line, it's a polyphasic kind of curve. It is not an exact replica of what we see in a normal child. So there is an irreversible change which occurs during the, this hearing impaired period into the brain. And that change, unfortunately, is non-recurrent. So these two charts basically compare the comprehension scores and the expression scores. And what we see in the children who were implanted much earlier, less than a year and a half of hearing loss, they parallel the normal hearing curves. As the hearing loss or the age of implantation increases by year, the recovery is much lesser and the gap is always there. No matter what we do, it is always there. And as the age of implantation progresses, the gap between a normal scores and a hearing impaired scores is significant. So what are the treatment options we have in children with hearing loss? Yes, as IAP suggested, we can go for hearing aids. These are quick and easy options. Child with hearing loss, we give hearing aids, hearing is amplified. However, children who have got severe to profound loss, means those who have a hearing threshold of 70 decibel or more, the hearing aid just fails. It amplifies the sound, it amplifies the noise, and child is unable to understand what is being said. And these children, they think it is a noise and they throw the hearing aids and don't hear it. And that's why these children, they hardly develop any speech and language. Whatever speech they develop, it's a deaf speech. We can make out deaf speech. It's a very high-pitched nasal voice. And these children are basically relying on lip reading, sign languages for communication. Cochlear implant pitches in where there is a 70 to 80 or 90 decibel of hearing loss. We'll discuss cochlear implant later. There is another called a bone conduction implant system. Bone conduction implant system is basically for pure conductive hearing losses. Children who are born with microtia, canal atresia on both sides. There is a conductive hearing loss, and this conductive hearing loss is bypassed by an implant which is put behind the ear. So this implant basically relays the sound energy through the bone, which is going directly to the cochlea. We call it bone conduction. So it is just bypassing the ear conduction pathway, and the child is hearing as good as a normal child. Well, this is a pivotal audiogram. It's slightly highlighted. What we see, a banana-shaped thing, is a normal range of conversation. Anything below that banana is significant because child misses the daily communication. This shaded area is an area where we consider a patient to be a cochlear implant candidate. However, the low frequency, they are sometimes preserved in some cases. Most of the times, the higher frequencies are not preserved. Any child who has hearing impairment above 70 is a candidate for a cochlear implantation. So they are just the basics of the cochlear implant. There is an implant and there is a hearing aid-like processor. So this processor is the actual thing. It is translating sound from being an electrical energy to a current. So it's bypassing the function of cochlea, and that current is relayed to this implant, which is stimulating the ganglion cells and the hearing nerve, and the brain perceives it as a sound stimulant. So that's the processor which converts sound to electrical energy. Yes, I must stress here, there's no part of implant is visible. It's all underneath the skin. A child can take out this processor and he's be as good as a normal child. There's nothing projecting out of the skull. How the information is communicated, there is a magnet here. So it's an electromagnetic flow of information from the processor magnet to the implant magnet, and through the implant, the energy or the information is relayed to the nerve. So that's how the implant works. The sound goes to the processor, then to the implant, and through the electrodes, which are stimulating different parts of the cochlea, depending it's a low frequency or middle or a high frequency sound, and then all the way through the nerve to the brain. So cochlear implant candidacy, yes, children who has got preserved low frequencies and affected high frequencies. Children who have a severe but progressive kind of a loss. Child who has meningitis, the loss is progressing. Whatever we do, it is not stopping. And these become the candidate for cochlear implantation. In adults, the children, some of the children have acquired hearing loss. They had meningitis or they had trauma, the hearing is impaired. We give them hearing aids. And in spite of having best of the hearing aids in both the ears, a child is missing out on 60% of the words. And then we say that, yes, he or she is a candidate for cochlear implantation. So what are the factors which predict the success of cochlear implantation? The number one factor is the duration of deafness or the age of implantation. We implant them early, we do not see any difference between a hearing impaired child and a normal child. We implant them late, no matter where we go for therapy, the gap will always be there. Other factors depend on the degree of hearing loss. Yes, candidates who have a preserved hearing in certain frequency, they definitely tend to do better. compared to individuals who have no residual hearing in any of the frequencies. Those who receive benefit from hearing aids are good candidates because they have a habit of wearing something on the ears. They go to the therapy sessions, and this transition is much smoother. Yes, there are certain radiological and medical considerations. If there is cochlear anomalies, the outcomes vary as per the severity of the anomaly. And sometimes the family expectation and support, yes, sometimes the child is being brought late for implantation and family thinks, yes, if we put a CI, the child will speak the next day. That is not good. So we tell them, as per the age of presentation, what are the realistic expectations a parent can have from us. Sometimes the parents say, yes, we live far off, we get the implant, what about the afterwards? So we said, no, you have to stay in the city and take therapy. The sound is not as good quality as a natural sound. So there needs to be some training of the brain to understand this slightly abnormal sound so that the brain can understand it and then only the child will speak. So a good auditory verbal training, which are provided by therapists, is very important after CI surgery to have the maximal outcomes. So how is the journey to the better hearing? Yes, first we evaluate the candidacy, we go for the surgery. After the surgery, we switch on the device. We attach this processor onto the magnet of the implant. We usually wait for a week or so for the swelling to subside, the healing, all the stitches have been taken out. And then we put on the implant, which we call switch on. It's the first time the child starts to hear. Then the habilitation part or auditory verbal training part starts. And then as per the need of the child, we try to maximize the child's potential.
So what is the earliest you have done surgery?
And 9 months.
Youngest.
9 months prior. So that child was a child of doctors. They were from Jammu, and the mother was a radiologist, father was anesthetist. The mother had a rubella infection during pregnancy. So they were aware, the child may have a hearing loss. So they diagnosed by, I think, by 6 months of age. They took certain opinions. By 9 months, we implanted. 2 years later, when the father came for some paperwork, because he works in a university, so he wanted to get some reimbursement. So I asked the parent, what do you think is the problem in the child? He said, no problem. There must be something which teachers are complaining. So we say that teachers कहते हैं बच्चा बोलता बहुत है.
Normally, I had 2 kids with zero hearing, and dono ka at birth screen was normal, and they were diagnosed around 8-9 months. What are the basic symptoms to expect? Hearing screen is normal, and still the child would be deaf. And what symptoms we should expect at 7 months or maybe 5-6 months, which warn us, taken as red flag signs?
Most of the times, it is the fault at the level of testing.
So forget about that. No, we are not discussing that point. What to look in the child?
The thing is, the best person to ask is the mother. Mother knows the child is hearing or not. A mother always has suspicions. Yes, जब मैं उसके साथ बातें करती हूँ, I make sounds. He doesn't get eye contact. He doesn't turn the head to either side. Okay. And if it is a delay onset, yes, the language is delayed. The monosyllables, the bisyllables, they are delayed.
Also, the start and response नहीं होता. Start and response नहीं होता. तो जोर से दरवाजा पटाखा बजा तो ऐसे नहीं चौंकता बच्चा. That is first of signs when we see for 6 to 7 months. फिर बच्चा 6 to 7 months में ना आवाज की तरफ ऐसे घूमने लग जाता है कि किस तरफ से आवाज आ रही है. So if the parent, mother, दादी यहाँ से बुला रही है, मम्मी कहीं से बुला रही है, तो वो at least गर्दन घुमाकर वहाँ देखता है. वो नहीं देखता है. वो फिर 6 to 7 months के बाद they start going papa babbling. If that is also not coming and आप बच्चे को बुला रहे हो and he's not turning when his name is being called, because by 6 to 7 months उनका नाम बुलाओ जोर से तो वो turn करते हैं. वो भी नहीं हो रहा तो these are alarming signs कि क्यों नहीं हो रहे, ये सब होने चाहिए. So that is what when we do hearing screening, we have attached a developmental profile, basically breath pointers, जो parents देखते चलते हैं at their level कि ये हुआ नहीं हुआ. अब नहीं हुआ तो definitely the assessment has to be done, क्योंकि अगर सब चीज normal है, बच्चा वैसे cognitively ठीक है, आपको पता चल रहा है कि आप interact करो तो interact कर रहा है सामने से, पर पीछे से नहीं कर रहा. So there has to be one reason कि वो पीछे से क्यों नहीं कर रहा. Auditory responses are always in response to some sound. तो मम्मा कुछ गा रही है या बच्चा रो रहा है, माँ चिल्ला रही है, आ रही हूँ बेटा आ रही हूँ, और वो चुप हो जा रहा है. That means कहीं ना कहीं audition है, but वो नहीं चुप हो रहा है and he's still crying, because this is one of the parameters that we check.
I was coming to that, in both kids, the only feature I could notice was both the children were crying excessively. To an extent that their neighbors knew that in the night they are going to cry like anything. So this was the only clinical symptom or whatsoever I could notice. Apart from this, nothing was significant.
But OA can be normal and still have hearing loss. OA will not
Yes.
pick up everything.
So,
na?
sir,
That
there
is
is-
one reason.
There is
It has a
condition-
high this rate. I mean, it will wrongly diagnose a person with hearing loss. OEs will not miss it. वो गलत हुआ है तो ही पास है. वरना अगर हम normal बच्चों में भी testing जब करते हैं, we have seen when we put this thing to the ears, it comes as a refer, and then parents are like scared. Then we tell them कि debris होगा, कुछ fluid होगा ear में, इसलिए negative आया. तो वो rescreening जब हम करते हैं तो वो ठीक हो जाता है.
It is reverse. Okay,
So,
OA is
हाँ,
fast, so it is
OEs will
fast.
not miss. वो मतलब it is very very sensitive.
Okay.
वो एकदम ही debris में भी negative दे देता है.
It will
ये-
test only till inner ear or something.
Yes,
na?
hair cell level. That's it.
NSD में OIs will be pass.
बाकी 7 months
तो
is too late.
neuropathy
I
किसी
think
को
2 months तक पता चल जाता है.
OI pass है.
7 months is
Yes,
fine.
sir. Abhi next presentation I will be discussing the protocol. It has revised now.
So we need to, if we are suspecting that we should go ahead with both the things.
Yes, yes.
कुछ
If
flaw
Even
होगा.
if OA is
Test
normal, we
when
should
you
go ahead
were
with Bella.
नहीं, if this is a well baby who has not been referred to NICU, then आप अगर OE करा रहे हैं it's passed, then I think there's nothing to be done. वो just progress देख सकते हैं बच्चे का, he is progressing normally. But if it's a NICU baby, उसका hearing screening हुआ है, उसका नहीं पास आया है तो rescreening भी नहीं हुआ है, so within 3 months के अंदर उनका बेरा हो जाना चाहिए. At risk babies का बेरा हो जाना चाहिए.
Within 3 months of life.
Within 3 months, yes. within-
कितनी जल्दी?
We have done for kids as young as 1
Graduates
month.
को हम Bella करा
करा रहे हैं. Same.
3 months.
Even those kids who are having a hyperbilirubinemia,
Yes,
more
sir.
than 20
Yes.
levels,
They are
they should
high
also
risk,
get paratestin at 4
Right.
weeks.
Yes.
of this.
High.
क्योंकि उनमें NSD होने के chances बहुत ज़्यादा होता है.
So in auditory neuropathy, the signal is going to the brain, but it's not a sequential stimulus.
What is the cost of the implant?
I'll come to that.
प्लांट तो मारुति 800 से लेके ऑडी तक की कॉस्ट है.
I'll come.
OE तो क्या है? OE. ABR ma'am की specialized hairstyle has to be done by trained professional because उसके ऊपर सारी implementation है. So that is over 3,000 to 4,000 range.
और OA का 800.
सभी
या जैगुआर वाला.
Next.
So sometimes parents say कि हमें तो सर्जरी नहीं करानी है, बच्चा छोटा है तो आप hearing aid ही लगा. We'll continue, we'll see for 2-3 years और फिर देखते हैं क्या. So this is a graph which tells the chronological age and the language ability. It is for study has been done with the children who followed for 6 years of age. And for a normal individual with a normal hearing, the progression is good. Individuals who had an intervention at 2 years of life, when they were followed up with 6 years, and these were the green line were the hearing aid users, the gap was always there in the language ability. However, when we do a CI, a cochlear implant here, the gap bridges by 6 years of age. So CI has the potential to bridge the gap between a hearing impaired and a normal child.
So we'll be able to assess the real effect of cochlear implant once the child grows and is like reaching till about 5-6 years.
It's a
Like you said,
rehabilitative.
expectations.
And there are two
Parents
aspects.
should not be having too much
No,
expectations.
no, I can come to that. There are two aspects. One is the hearing, and that is the speech. Okay. The hearing improvement is very much significantly observed by 1 month implantation. Okay. So you can see the child starts responding to sound, to whatever name calling or startle reflex, it's there. The language takes longer. So what we say, you wait for 9 months to learn it for the language or the speech to learn.
And after a cochlear implant, how frequently a child needs to go for their training sessions so as to have
Those
that
are regular. And the
And how-
recommended frequency is twice a week they have to.
twice a week.
Because whatever we do, the parent has to do it. They have to do it. Then only the child will reach that potential.
But language is which I have seen,
Implant is
they
also
have,
depend on age.
Yes, sir.
If a child is at 9 months, So probably he will
require less intervention.
less intervention. But if the child is 6 years,
They will,
Yes.
yes, the window is closed.
because already 6 years
2
gone.
years. Yes.
6 years plus. What I
हाँ वही खत्म हो गया उसका न्यूरल रिग्रेस हो गया उसका
So what is the best age for implants? The answer to your question, sir. The best, the 4 to 5 years of life is critical for language acquisition. Afterwards, we put the child on implantation. Yes, he may have some speech, but language will not. So the best time is yes, less than 2 years. Yes, 2 to 4 years, we can also intervene. The results are good. After 5 years, the outcome depends what intervention has been done in last 5 years. The child has one hearing aid.
Hello. Yes.
So if the child has one hearing aid in last 5 years, yes, implants will bring about a good result in those cases. Children who were totally deaf, did not have any amplification, no hearing, no therapy, they will be a poor candidate in terms of language development. Yes, some amount of speech may develop. Hearing though will be restored completely. So there will be a drop, there will be a bell, the child will stimulate and we will turn to the sound of the bell. However, the discrimination ability may or may not be there depending what is the intervention is given. So early implantation have significantly, it impacts, the outcome is impacted by early implantation. These children, those who are implanted or those who are intervened below 6 years of age, they go to a normal school by 3 years of age. And these individuals at school level, they have equal, say, scholastic development compared to normal hearing peers. They have better speech intelligibility. They have more opportunities in employment, and thus they are a less burden to the society compared to the hearing impaired.
Sir, no, after hearing is restored even with hearing it, no?
So the thing is,
Cochlear was not done. It is already late. So hearing it is continuous, so hearing will be there, na? Speech will not be there.
so the thing is, the block is at the cochlear. The hearing aid is amplifying sound and going every to the cochlear. Cochlear is not converting those sound to the electrical energy. And that's why the sound is not being passed to the brain. So no matter what we shout here, it's only a significant portion is going, insignificant portion is going to the brain. The rest is blocked by the cochlear. So the hearing aid will stimulate, but he will not understand because understanding is bad.
What is the life of cochlear implant? It's for lifetime.
And the youngest children which was implanted was at 4 years of age. She is now 38. And she is using the first generation implant. She is a lawyer in Sydney or somewhere. And she is practicing on it. So her first generation research implant is still there.
the house is
With the
process
first
of generate
implant.
energy by itself. We use the
So it has a rechargeable battery.
rechargeable
That we have to
Every night
how
it
much
has
times? 1 day.
so that
So during the day, child wears it. At the night, he puts it in the
Only
charger.
3 to 4 hours charge with 12 hours, 14 hours, 1 day.
And the hearing is through the implant. The implant is not restoring the natural hearing. It is just bypassing the pathology. The pathology in the cochlear, it is just bypassing the cochlear. Nothing is being done to the cochlear. So, this is about the normal auditory development of a child. There are different levels how we measure the auditory development. Level 0 is no awareness of sound, and level 7 is the use of telephone. So normal children, they attain this ability to have conversation with the telephone around 2.5 years of age. Children who are implanted much sooner, less than a year age, they catch up very fast. Okay? Children who are implanted, say after 2 years, they will not be able to catch up, though they'll show a significant improvement after surgery. Children who are implanted later, around 4 years of age, they will never be able to have or reach that level of communication. Though they will improve, but they will not be able to reach that level of communication. That's why early implantation restores normal hearing and normal development. The same is true for the speech part. That was for the auditory part. This is the speech part. If we call the speech intelligibility, how clear the child can speak so that people can understand. A normal hearing individual can speak as good as 2 and 2.5 years of life. Children who are implanted early, they reach that potential at almost the same time. Children who are implanted are later on, say after 2 or 3 years of age, they take much longer to reach that level. The same is true for the education placement. This study is from Germany, so there are different types of schools. Here we have only a tech school and a mainstream school. Children who are implanted less than 2 years of age, almost 70% of them went to the normal school. Children who were implanted after 4 years, only 14% of them went to the deaf school, and hearing aid 12%. So hearing aid is as good as a late implant, okay, with the best of the efforts. This is our study. We followed around 250 cases. We published as well. So this is the, so we implanted almost and we use different manufacturers, Cochlear, Advanced Bionic, and Nebulic. So let's skip this one. Educational basement. Yes, children who were implanted, as we followed them up, by the time they become 2 years of age, most of them went to the mainstream school. The yellow is the mainstream school. So at 2 years post implantation, they went to the mainstream school.
Service need to be the best like.
इसको नहीं चला
So this is the auditory performance over a period of time. Children who at the time of surgery, they have no awareness of sound. At 1 year of surgery, they can discriminate between different sounds without lip reading. At 2 years, they can understand common phrases without lip reading. By 3 years, they can understand normal conversation without. So how frequently or how commonly we see child changing from gestural or communicative mode to an oral mode? Yes. So at baseline, when the child was implanted, the communication was all gestural, and by 3 years of age, it all becomes oral. So that is it. I thank you for your presence here. In case you want to ask questions.
One question. Does this disability certificate or disability rules apply even after implant?
Yes.
Sir, cochlear implant.
Pre-cochlear implant and post-cochlear implant.
Disability is about the natural disability. So the percentage of hearing loss is calculated as per the natural.
But once it is restored,
So it's still a device. The government does not withdraw the benefits of it.
So बिना device की तो disability गई नहीं ना. Device हटाओगे तो disability तो है ही. Can't cure the child completely.
So yes, some questions will people ask.
I think cost is one thing where everybody wanted to know.
Okay. Sir, the implant, the cheapest implant costs around 6 lakh rupees. Okay, and the state of the art recent implant, which is available in America, that costs around 15.5.
this is for 1 year.
Yes,
1 year.
for one side.
1 year.
And it's just the implant cost. Other costs.
Other costs are
15 to 16 lakhs.
Is it covered by the TK?
Sir, congenital losses are not covered by TK, but if it's an